And I would like to invite our second speaker for the second scientific session, which is Cognitive Dysfunction in Diabetes Mellitus. And our speaker for today is Dr. Dysfunction Guin, who is ex-assistant professor BIN, Bangalore Institute of Neuroscience, and is a practicing neurologist in Howrah with 10 to 12 years of experience. To chair the sessions, I would like to invite Dr. S.K. Somani, who is a founder member and member scientific affairs of HDS. He's a very senior, reputed neurologist of Howrah. And along with him, Dr. Somnath Noshkar, who is an active general medicine practitioner with special interest in medical education service. The speaker and the chairpersons, I welcome you all.
So the talk for this session is Cognitive Dysfunction in Diabetes. It is very interesting and paradoxical that we discuss a lot about peripheral nervous system involvement, but cognitive impairment doesn't find much of talks in our day-to-day or conferences. And this topic is consistent with our theme, more in diabetes. I would like to inform that way back in 1922, an interesting article on cognitive dysfunction was published in Archives of General Medicine by Miles and Root. But since then, there has not been much talk about this aspect. And for this talk, we have Dr. Dysfunction Guin to enlighten us about cognitive dysfunction in diabetes.
Thank you, Sumanida. Good morning, everybody. Today's topic is cognitive dysfunction in diabetes. As we all know that prevalence of diabetes is on the rise. Within next 30 years, the number of diabetic patients will double in comparison to the year 2000. We also know that diabetes is amongst the disease with highest complications, including microvascular as well as the macrovascular complications. Adverse effect on diabetes on cognitive impairment and memory disorder has been noticed by researchers for a long time. And we equally know that dementia is among the most disabling public health problems affecting the quality of life of demented patients as well as the caregivers. And it is a huge burden, both economic and psychological burden to the society, especially the caregivers. We all know that India is going to be the diabetic capital in near future. Presently, it is the second most populous diabetic country. We also know that the population, especially elderly population in our country, is gradually rising. In 1960, the percentage of elderly population was 5.6%. And in 2011, it is going 8.6%. So elderly population is growing and diabetic population is also gradually growing. In this slide, we can see that the number of diabetic population is gradually higher as the age increases. And it is most prevalent in 70 to 79 years of age. It is 13.2%, whereas in general it is 11.8%. The association between the diabetes and the cognitive dysfunction is known for a long time. It has been shown that there are diabetic patients, especially elderly, are 2 times more likely to develop dementia than older adults without diabetes. Now, here is some overview of memory and cognition. What is cognition? Cognition is defined as a mental action or process of acquiring knowledge and understanding through thought, experience, and senses. And memory is the retention, recording, and process of retrieving knowledge. Passage circuit is a brain circuit which is most important in processing of our recent memory. It starts from the hippocampus. It starts from the hippocampus through the fibers of the fornix. It goes to the mammillary body. Then from the mammillary, through the mammillothalamic tract, it reaches the anterior nucleus of thalamus, and through the then it reaches the cingulum. Through the corpus callosum, it reaches the entorhinal cortex back to the hippocampus. So this is the circuit which is most important in processing of recent memory. There are three major association areas which are mostly involved in cognition. These are this parieto-occipito-temporal association area. Next is prefrontal association area, which is mostly involved in the walking memory. And third is the limbic association area in the medial temporal lobe, which is mostly involved in the consolidation of recent memory. Now, there are the types of age-related cognitive impairment. The cognitive impairment is a continuous process, is a continuum. Ranges from the normal cognitive impairment to mild cognitive impairment to major cognitive impairment. And the spectrum of cognitive changes ranges from asymptomatic state to the normal cognitive aging, then subjective cognitive aging, then mild neurocognitive disorder, then major neurocognitive disorder. It is a continuous spectrum of changes. There are these among the cognitive functions, the process of processing speed, working memory, and inhibitory control. These three parts are mostly vulnerable for aging. And in the lastly, there is involvement of the long-term memory and the sensory perceptions. Now, mild neurocognitive disorder or mild cognitive impairment. What is this? This is a significant but less severe cognitive deficit. It needs to develop compensatory behavior that limit impact of cognitive decline, may need more accommodation to maintain day-to-day function. It interferes with the day-to-day activity. Interference with the day-to-day activity may not be noticeable, but higher cognition is likely affected. So, mild cognitive impairment, that is, the cognitive impairment is normal for age. Patients are not demented. Cognitive decline is objective, essentially normal cognitive functional activity. And MCI is divided into two. When the memory is impaired, it is called amnestic MCI. When it is not other than memory domain, like language, like praxis, and other cognitive domain other than memory is involved, it is called non-amnestic MCI. Now, among the amnestic MCI, when the only memory is impaired, it is called amnestic MCI single domain. And when there is along with memory, other domains are involved, it is called amnestic MCI multi-domain. Similarly, in non-amnestic MCI can be single domain or multiple domain MCI. Now, major cognitive disorder or dementia, it is defined as a significant cognitive decline from previous level of performance in one or more cognitive domains. The cognitive deficit that interferes with the activities of daily living, and it is not a state of delirium or other mental or psychological disorders. Now, the executive function. What is executive function? Executive function is referred to the mental process that enables us to plan, focus attention, remember instructions, and juggle multiple tasks successfully. And it is the executive function that mostly involves in patients with diabetes. One example of executive dysfunction is, suppose your patient is an elderly professor starting a new meter of insulin device. He may be highly literate and well-read. That is a crystallized. That is past memory is good. He's quite intelligent, but that does not guarantee he grasped your instructions for how and when to use this new device. That is the recent memory or the working memory or executive function may be impaired. Now, what is the association between the diabetes and cognitive decline, and what is the evidence? It is known since 1920s, Miles and Roof et al. First published in Annals of Archives of Internal Medicine, 1922. They have concluded that abnormalities of glucose availability to the brain, such as diabetes, might lead to the brain processes becoming compromised. Other literature, Wessels et al., in a study involving 1,700 patients, concluded that diabetes mediated by cerebrovascular pathology accelerates cognitive decline within a follow-up period of 15 years in a sample comprising African Americans. This is another interesting study where Chinese population and American population are compared for cognitive changes in diabetic patients, and they have concluded that diabetes is associated with cognitive dysfunction, in particular exerts a negative impact on executive function regardless of race, age, and prevalence of vascular risk factors. One interesting study, ACCORD study, that is Action to Control Cardiovascular Risk in Diabetes. This this memory in diabetic subgroup, they have concluded that neither intensive glycemic control or nor blood pressure control has shown to prevent a decline in brain function. Swedish National Diabetes Registry has mentioned in type 2 diabetes, Hba1c in excess of 10% is substantially increased the rate of dementia. There is no dementia risk at Hba1c level less than 6.5%, but it gradually increases thereafter. This is the official website of federal government of USA, and they have mentioned emerging issues of diabetes in 2020. The evidence is emerging that diabetes is associated with additional comorbidities. These are new from the conventional complications of diabetes. These include cognitive impairment at first. Others are incontinence, fracture risk, and cancer. These are the new complications or comorbidities associated with diabetes. A consensus report in diabetes in adults have mentioned that Alzheimer's type and multi-infarct dementia are approximately twice as likely to occur in those with diabetes compared to the age-matched non-diabetic control subjects. The presentation of cognitive dysfunction can vary from subtle cognitive dysfunction to overt dementia or memory loss. So all forms of cognitive dysfunction can be associated with diabetes. Hypoglycemia. Hypoglycemia is a risk factor, is linked with the cognitive dysfunction in a bidirectional fashion. How? The cognitive impairment increases the substantial risk of hypoglycemia. So in a demented patient, the self-management of diabetes is hampered, so there is a high risk of hypoglycemia. Conversely, a history of severe hypoglycemia is linked with the incidence of dementia. The more the hypoglycemic episodes, the more patients will be demented. ADA Standards of Care 2016 has mentioned that older adults with diabetes at higher risk of cognitive decline and institutionalization. The presence of cognitive impairment ranges from subtle executive dysfunction to memory loss to overt dementia. And they have also mentioned that presence of cognitive impairment can make it challenging for clinicians to help their patients to reach individualized glycemic, blood pressure, and lipid targets. Cognitive dysfunction makes it difficult for patients to perform complex self-care tasks such as glucose monitoring and adjusting insulin doses. There are several studies which shows that there is close association with the diabetes and vascular dementia, about 100 to 160% compared to Alzheimer's disease, which is about 45 to 90%. Long-term risk of dementia increases in patients of diabetic by factor 2. That is twice the risk of dementia in patients with diabetes. Diabetes also increases the risk of progression to mild cognitive impairment to dementia. So those having mild impairment, poor diabetic control will lead to more progress to dementia. There is a faster deterioration of cognitive dysfunction in diabetic patients rather than non-diabetic elderly ones. And subjects with diabetes has a lower MMSE score than without diabetes. Now, how it differs from type 1 and type 2 diabetes. A meta-analysis involving type 1 diabetes, aged 18 to 50 years, have mentioned that the magnitude of cognitive dysfunction is moderate. Most tests examine ability to respond rapidly, and cognitive slowing is the fundamental deficit, not the memory. The differences in the cognition emerges early, that is within 2 years of diagnosis, and children's brain is more susceptible than adults. Those with the onset less than 7 years of age have a higher risk than the olders. In type 2 diabetes, another study, Rotterdam study 1999, involving more than 6,000 patients, they have concluded that patients on insulin are at highest risk of dementia. Population attributable risk of diabetes to the incident dementia is 8.8%. Another study involving 961 patients with baseline MMSE more than 26. After 4 years follow-up, they have concluded that compared to those who had normal glucose or impaired fasting glucose, people with diabetes has a lower score on test of psychomotor speed, attention, and verbal memory. Another study involving women ranging 65 to 99 years, they have concluded that women who had diabetes more than 15 years had more cognitive impairment than at baseline. So, in summary, type 1 diabetes has the following defects, that is information processing, attention, visual construction, mental flexibility, and psychomotor efficiency. But memory is relatively intact. It's not shifting. Page is not shifting. अटके गया लगा ঠিক হচ্ছে না কেন বারবার হচ্ছে না কেন And in type 2 diabetes, the most cognitive part that is affected are information processing speed, attention, executive function, and verbal memory. হচ্ছে না কি হচ্ছে মুভ করছে না কেন
এগুলো দিয়ে হচ্ছে না
কখনো করছে কখনো করছে না ঠিক আছে ঠিক Now, diabetic retinopathy and cognitive impairment. It has been shown that diabetic retinopathy was more strongly linked to the impairment of cognitive domain of verbal learning and recent memory. In a study, Accord study, that is, has mentioned that the association between diabetic retinopathy and cognitive impairment diabetes was confirmed, and it has a patient who is diabetic retinopathy had lower mini-mental state scores. In another study by Cosby et al. Mentioned that patients with minimum diabetic retinopathy, this is very interesting, patients with minimum diabetic retinopathy demonstrated more cognitive impairment than those with advanced diabetic retinopathy. Therefore, increased prevalence of cognitive impairment in diabetes may be associated with factors other than evident retinal microvascular changes. So, this cognitive impairment may not be only vascular, other pathology may be there. Now, brain imaging diabetes. Brain imaging is an important tool to clarify the underlying pathogenesis of cognitive impairment in diabetes. The gray matter density is altered. Diffusion tensor imaging is an important tool. Type 2 diabetes shows that in type 2 diabetes there is a significant brain atrophy. It is similar to seen in Alzheimer's disease. Now, what are the pathology? What is the cause of this cognitive impairment? It may be multiple. It may be vascular. Hyperglycemia itself can cause some changes in the brain. Insulin resistance, amyloid deposition in single or combination leads to cognitive impairment in diabetes. This is a complex slide showing multiple factors, including conventional risk factors, genetic factors, oxidative stress, endothelial dysfunction, and insulin resistance, leading to this both vascular pathology and Alzheimer's pathology in diabetic patients. Especially insulin resistance, which is most important, impairs A beta protein clearance, increased A beta protein deposition, increased tau phosphorylation. All this leads to Alzheimer's type of pathology in the brain, and these are conventional factors like micro and macrovascular factors leads to vascular changes in the brain, leading to dementia. Now, how can we detect timely a patient with dementia? This is a shortcut test you can apply in a day-to-day practice. It's a mini cog test. It is a quick screening test for significant cognitive impairment in people with diabetes. Step 1, ask the patient to repeat 3 unrelated words: apple, table, penny, or paisa, and remember them. Then step 2 is ask the patient to draw a clock face. Draw a large circle, put numbers so it looks like a clock, and set the time 5 to 3. If the clock is normal and sets correct time, and all numbers are roughly correct position, then if ask the patient to recall the 3 words. If patient cannot recall any word, then patient is demented. If the patient can recall 1 or 2 words and clock drawing test is abnormal, then patient is demented. If the clock drawing test is normal, patient is non-demented. And if patient can remember all the 3, then patient is not demented. It has a sensitivity of 86% and specificity of 91%. Now, therapeutic approach. Good control of diabetes is beneficial in reduction of the cognitive decline in type 1 diabetes. But the effect of this approach is in type 2 diabetes is controversial. A greater decline in cognitive impairment in patients with anti-diabetic medication has been shown. In ACCORD trials, has shown that no benefit of aggressive glucose control on cognitive function. In one study, daily glucose fluctuations was the independent risk factor for cognitive dysfunction. And hypoglycemia. Hypoglycemia is an important preventable risk factor for cognitive impairment in diabetes. As the times of hypoglycemia increases, there is an increased risk of patient is demented. So it's a significant preventable risk factor for dementia. Thiazolidinedione classes of antidiabetic has promising results in cognition in mice model brain, but this clinical trial in human is disappointing. Intranasal insulin has shown effect in some on memory function in some studies. This is a diagram how we can approach a demented patient, a patient in a dementia setting, and in diabetic care setting. As we can progress in dementia setting, in step 1 we should screen every demented patient for diabetes annually. In the next step, we should consult a diabetic expert for alleviating diabetic symptoms with medications with a fasting blood glucose level 7 to 9 millimole. Then we should screen for complications and eliminate diabetic symptoms and concurrent infection that may exacerbate confusional state. In step 3, when the patient is more demented, we should reduce the complications like eye and feet complications, reduce fall, and prevent hyperglycemic symptoms and good nutrition. And in the last phase, when the patient is more demented, we should simplify the diabetic medication so that, and we should prevent acute symptoms. In diabetic setting, in diabetic care setting, what should we do? We should screen patients for any cognitive impairment by applying MMSE or mini-cog test, assess the confusional state, and we should treat that such as infection and pain that leads to confusional state, and assess the cognition or cognition capacity, and in the next step, manage cognitive deficit and caregivers as a role in this
please wind up.
Stage.
The time is.
As the patient got more demented, we should simplify the diabetic regime. So in conclusion, diabetes, there is a strong evidence that diabetes increases the risk of cognitive impairment and dementia. Insulin signaling dysregulation is a maybe important contributing factor in Alzheimer's disease pathogenesis. Good control of diabetes is beneficial in reduction of cognitive dysfunction in diabetes 1, but the effect of this approach in improving cognitive outcome in type 2 diabetes is weak. Lifestyle intervention such as proper diet and physical activity is the most important approach in this way. Thank you for patient hearing. Now, a question for the audience. In which neural brain circuit is the most important in recent memory?
Yes, sir, you raised your hand at the back.
Pappage circuit. Dr. Bhargav Mukherjee from Howrah.
Sir, we have a small gift from HDS for you.
Okay, thank you, Dr. Guin, for elaborately discussing a topic which is less discussed and probably less understood also. And there is many, at the end of the topic, we get many food for thought. There's still scope for exploring the topic. We can come up with many studies with this. Anyway, if the audience have any question, 2 questions will be allowed.
Thank you, Doctor, for your excellent deliberation. My question is there any correlation between the raising of Hba1c with the development of multi-infarct dementia?
Yes.
Sir, is there any correlation between the raising of Hba1c with the development of multi-infarct dementia?
Yes, I have already mentioned that in up to 6.7, Hba1c 6.7, there is a chance of cognitive impairment is less. But as the Hba1c level rises further, there is a risk of cognitive impairment is more. And more than, if it goes more than 10, patient is a high risk of going to be dementia.
Role of statins and good control of blood pressure apart from blood sugar control. What are your views? Role of statin.
What?
Role of statins and good control of hypertension in diabetic patient.
You see, these are the conventional factors, statins and other blood pressure control. Statins, these are helpful in preventing both micro and macrovascular complications. So, diabetes with vascular cognitive impairment, this vascular part is can be controlled with these statins and other blood pressure, blood sugar management. But non-vascular part, that is the Alzheimer's pathology part, these management of this thing is little complex. There is not much linear correlation between the good control of diabetes and this pathology. So this part is not elaborated much in the studies. So vascular component we can control by statins and other conventional medications to prevent vascular risk factors.
Statins are known to cause dementia.
Hello. Thank you, Dr. Guin. As the subject is very complicated and not much discussed in conferences, I appreciate your studies for making the slides for this presentation. My question is very simple. Do you have any answer to my question? Diabetes, if you by treating the patient, if you cause hypoglycemia, it will cause the dementia risk. And if you do not allow hypoglycemia, maybe some amount of hyperglycemia, that will also increase the dementia risk.
Yes.
So it is a very messy situation. Can you suggest or appreciate any type of drug in treating diabetes or otherwise which can help in prevention of dementia?
Any kind of drug?
Any kind of drug or therapy.
That will prevent
this dementia in diabetic patients.
Actually, the anti-dementic drug which apply in non-diabetic patients can be applied both in diabetic patients also. So there is no new drug that can be only applicable to the diabetic patients. So the drugs we apply in non-diabetic demented patients like donepezil, memantine, that can be applied to the diabetic patients also to prevent for at least stabilization of the dementia.
MCS stage.
Yes.
And we can use some drugs that will control the blood sugar but will not cause the chance of hypoglycemia is less. That is one.
Yes, that's also another point. Thank you.
Thank you.
Another question.
Not a question, just a rejoinder to this discussion. Actually, there are some studies.
So this is the last question we can take. Okay.
This is not even a question. I'm just answering in one line. So sitagliptin has been shown. There are some studies to show that cognitive decline is less. So just he was speaking about that. So this can also be one drug which is controlling the sugar as well as maybe retarding the decline in cognitive function.
Well, metformin is to some extent in this way can control blood sugar and some cognitive improvement. Thiazolidinediones and anti-diabetic has shown in mice model, but not in humans.
Thank you. Thank you.
Okay, thank you all. We are going to end the
Thank you
session.
so much. Thank you so much. Speaker and chairpersons, please stay with us for a while. We have a small token of appreciation for you. To give away that, I call on stage Dr. Emil Bhansali, the Vice President of HDS.
স্যার কোথায় গেল?